Assalamu alaikum. Welcome everyone. Today it is our 17th session, master class on online academy of otolaryngology and head neck surgery, and I like to invite you all to today's session. And today we will be discussing about the laser in otolaryngology. Laser in otolaryngology will be presented by Professor Kamrul Hasan Tarafder. He is our ex-president of our society, as well as still he is professor of otolaryngology and head neck surgery in Bangabandhu Sheikh Mujib Medical University. And I do not like to mention other lot of things he is associated with, including the president of the SARC Society's Association of SARC ET Society. And today, in our session on laser on otolaryngology in this academic platform, I like to mention that our panelists are Professor Firoz Ahmed Khan, Professor and Head Bangladesh Medical College in Uttara Adunik Medical College. Professor Sheikh Hasanur Rahman is professor in Bangabandhu Sheikh Mujib Medical University. Professor DGM Akaiduzzaman, head Midford Medical College, and is professor and vice principal of Midford Medical College. And Professor Nurul Fattah Rumi is the professor and head of the Department of ENT in Dhaka Medical College. And Professor M.A. Motin is professor and head of the Department of Shohid Sohrawardi Medical College. And Colonel Basiruddin from Army Medical Corps. And we welcome and all of our panelists, as well as our speaker is already present here. And we would like to mention the primary thing is that the laser in otolaryngology have come as a long question as well as in short question in lot of times in fellowship and masters, and as well as in DLO and all examinations in Bangladesh examinations. And today our top-notch teacher, Professor Kamrul Hasan Tarafder, will highlight the important points that we have to remember in working with the laser, as well as to know the basic things of the laser, for the safety of lasers, as well as we have to write something in examination in the papers, as well as answering Viva question. So, Professor Kamrul Hasan Tarafder, sir, please you start your presentation. You share with your sounds. Please mention your video sounds in your presentation beginning. Thank you, sir.
Welcome, sir. Welcome. I'm a bit nervous. Today actually is the World Health Day, building a fairer and healthier world. 7th April is World Health Day. In the name of Allah, most gracious and merciful. Bismillah ar-Rahman ar-Rahim. So topics is laser in otolaryngology. So now, what is laser? Laser is an electro-optical device that emits organized lights in a narrow intense beam. Light amplification by the stimulated emission of radiation or laser, it is commonly known today, is an acronym whose theoretical basis was theorized by Einstein in 1917. And in 1960, Mayman produced the first laser. In the early 1960s, otolaryngologists first considered different methods using pulse laser system in the middle ear and labyrinth. And in the late 70s, the Boston people, JACO, starts the carbon dioxide laser mainly in the laryngeal area. It's nothing but the light amplification by the stimulated emission of radiation. In 1964, Patel at Bell Laboratories developed the laser. The first laser to operate successfully was designed in 1960, and it was ruby laser. The basic principles of laser. Today, lasers are used for a wide variety of purposes, including but not limited to medical, industrial, consumer electronics, and research purpose. The quantum physical basis for lasers involves an understanding of the electron energy levels and atom, the most stable level for a given electron in the ground state, in the transition between different energy states and electrons. Why you are talk with the laser? And what is the difference between the laser and our ordinary light? As Mayman first produced the laser. Ordinary light versus laser light. In our young child life, we have seen this main light is come from the sun rays. And when by placing a mirror and placing this light to the paper, there is some burning of the paper. In this way, the thinking of laser comes. Radiation, ordinary light versus laser light. Radiation comes from a conventional light source in ordinary light and emitted over a wide range of wavelengths. So many wavelengths is there, but laser has single wavelength. In normal light, intensity is more near the source, but in the lasers, the intensity is greater at the end. In contrast, laser produces a beam with a very narrow divergence, but for the lasers, it is convergence. So electrons are stimulated by external photon to emit their stored energy of photons. Photons now strike other excited atoms to lines even more photons. What are the properties of laser? It is monochromatic, that is single wavelength. It is collimated, runs in parallel direction. It is coherent. All waves or photons travel in steps or in phase with one another. What are the types of laser? This is solid, liquid, gas, semiconductor, excited dimers. So solid is YAG laser, liquid carbon dioxide laser, gas helium lasers, and other the diode lasers. In ordinary light, radiation from a converted light source is emitted. Beam leaves the source randomly, but lasers is a very convergent light is there. Both ordinary light and laser light can cause some of the complications, especially on the skin and eyes, may cause irreversible damage to the skin and eyes. Even sunlight may have a thermal effect, ranging from protein degeneration to the vaporization. So in the laser, the vaporization is more. What are the common lasers used? Yes, carbon dioxide laser. Carbon dioxide laser, you know the wavelength is 10,600. Typical application generally in cutting, strongly absorbed by the body fluid or water. The otolaryngologist, especially what is the important thing in the otolaryngology? What is the application of laser? Because we know that in our otolaryngology, our pathway is closed, both in the oropharynx, laryngopharynx, aeropharynx. So there is a closed area. There's a peculiarity is lined with a very vascular mucosa, and it is a block tube and dark tube area. Especially where surgeons are mainly used to using the scalpel or other blades for cutting. So what is the important? As there is a vascular mucosa, in any cut, there is a bleeding. And but in the laser, up to the 0.5 millimeter of blood vessel, so it can, without any minimum bleeding, we can cause the incision or excision or evaporation. The things can be done by the laser. In ENT practice, we are more interested with the carbon dioxide laser, diode laser, KTP laser. Other lasers are used. But the thing is, carbon dioxide laser, about where the wavelength is 10,600 nanometer, it is no light. But it is superimposed by the HE, helium and neon laser, the red one. The ruby laser is red, the KTP is green, argon is green, xenon is ultraviolet, but carbon dioxide looks red, but actually is not its color. How the lasers works? By the laser, one thing, it comes from a source. Laser machine, you have seen. Previously, the lasers are with the fiber. Say diode has a fiber, big thing from a source. But carbon dioxide previously, there was no fiber. And carbon dioxide was from a source of area. It is from the scanner mode. How we fire the area by continuous wave, operates in a continuous output for a period of 0.25 rather by pulse, by super pulse, by Q switch laser. Super pulse less than 0.25 second, and Q switch laser 10 nanosecond. So why we are thinking of the carbon dioxide laser, especially for the otolaryngology? As the laser comes from the optical cavity, it contains a lasing medium to be excited with the mirrors to redirect the emitted laser photons back along the same path. Because you see, sunlight can be converted into a very convergence by mirror. So laser in light, by the force, by optimizing the different mirrors placed in each end of the lasing medium, laser beam passes through a lasing medium many times. Number of emitted laser photons is amplified, and at each passage, atoms of the lasing medium become excited by an energy pumping system. Excited atoms undergo de-excitation promptly and then stay at metastable state. Why we are thinking of this laser things? Because we like to cut the tissue. By scalpel, we give the incision. By our hand strip, we can make it deeper. How much deep? But the laser, you cannot give the sensation, because the laser beam, it cuts by vaporization, by coagulation, and by denaturation. For vaporization and cutting, soft tissue wavelength such as carbon dioxide, modality 10.6 micrometer is indicated. For coagulation in soft tissue wavelength, which is poorly absorbed, so YAG laser is indicated, especially in the esophagus and others. For hard tissue bone, it is also in the YAG tissue. So what is the indication for the surgeries? As we know, the cavity other than oropharynx, the laryngopharynx, is a very vascular mucosa. So we can work mainly on the soft tissues. Carbon dioxide laser, when we cut the tissue by a beam, now it is with the scanner mode, if and attached with the joystick. By joystick with pointing scanner mode, we can make narrowing the beam by small pinpoint, by cutting it, by smaller edge, the which area we are cutting, how much you have to cut. Because in a cancerous tissue, say in the early clotic cancer, we like to take a tissue. If you give the continuous way, there is a vaporization of the tissue. At that time, the margin, a cancer margin, you may not get. If you use the super impulse of pulse tissue, only 0.2 millimeter depth, in that cases, the area is not totally coagulated. So cancer tissue can be identified. In ENT surgery, we are using for snoring, obstructive sleep apnea, evoluperatoplasty, midline glossectomy, linguoplasty, laser palatine tonsillectomy, laser lingual tonsillectomy. Why you are talking about the tonsillectomy? In tonsillectomy, we can done, nowadays, we are lucky the carbon dioxide is equipped with a fiber laser, not only beam. So diode is also the fiber laser. Fiber laser is a fiber, only it is through only a either suction tube, or there are some of the tubes. In the target area, you can hit by its upper end. But in carbon dioxide laser, target area we hit from the joystick by examining the area through the microscope. But we prefer, especially nowadays in a unknown primary cancer. After all tests, only the neck mass is there. There is nothing in the oropharynx, laryngopharynx, or some of the areas, their area. In that case, nowadays tonsillectomy is indicated. In that case, tonsillectomy is better to taken with a wide margin from the tonsil area. And yes, in that case, a diode or carbon dioxide laser you use is a better option, because if these lasers are used, you are cutting only a wax. Thing is that the laser can block the hemostasis 0.05 millimeter of blood vessel. Bigger than that, sometimes you need the diathermy, both uni or molecular diathermy. Same, the patient who works with the evoloplasty, the laser is an important tool other than seizure or bipolar or cutting diathermy. In median glossectomy, why we are choosing the laser? Because main complication of the cutting teeth is thermal damage, either unipolar or bipolar or coblation or something else used. For the laser, the thermal damage is minimal. And if you use the scanner mode by pulse or ultra pulse mode. Why you are preferring otolaryngology? Preferring because in any cutting surgery, there is some sort of postoperative edema, there is some sort of hemorrhage. So in smaller vessels, superficial, both in the tongue and tonsil, the less bleeding. And even postoperative edema is less. Evaporation is less. So when you work on the, especially on the larynx, so there will be less postoperative anemia. Here will be geopardization of left. Patient not needs tracheostomy in that case in this area. So we prefer the carbon dioxide laser, or sometimes if the stenosis is more thicker, somebody is preferring the diode laser. Yes, CO2 laser is used for laryngeal nasal oral surgery. Diode is tracheal nasal surgery. Argon in ophthalmology and dermatology. KTP in stapedotomy. YAG in gastric, urology and dermatology. Especially in the gastric laser, YAG laser is used, making a pathway. Already I've told about the carbon dioxide laser. It has 10,600 nanometer wavelength, built-in coaxial helium neon, as there is no light of this. The helium neon laser X, there's red color is for that year. Focus to less than 500 millimeter and seals blood vessel less than 5 millimeter. Pulse to accommodate thermal relaxation time. Comparatively a poor hemostat. In that case, we need cauterization. This is a laser. We are very happy. In our setup, Bangabandhu University is seen one of the laser is a Korean laser. One is the Luminous, fantastic laser. Luminous, another is the diode laser. Luminous laser with the scanner, and other we can use the pulse, super pulse, continuous move, both. This is a scanner. How the scanner helps? The scanner, you see there is a prism. It can, from the light source, it can, by the beam, you can slowing the size, very small to bigger, even cutting size. And this is intensity is increased at the end. Lasers for bulky lesion, vascular areas. For this, proper training is important. Scanner allows different shapes and depth. Already I told, this is a micro debrider. 5,000, sometimes why it is useful. In otolaryngology, especially in otology, laser stapedotomy is helpful, because sometimes if you use a postoperative for fenestration, carbon dioxide laser in the scanner mode, very small, depth will be little, there is chance of perilymph fistula is less. Even if the argon laser is used in that laser, there is a history of injury to the spinal vascularis. In that cases, career may happen. So somebody should think before they're using laser and stapedotomy. Very important in recurrent respiratory papillomatosis, because in our country, we are not using the antivirus, especially the human papillomavirus, main responsible. We are getting a lot of patients from age 2 to even age 18, 19. There is a history of, even in our country, more than 15 times of the surgery. And every time there is some injury of the respiratory epithelium, every time there is a chance of enterosynechia, chance of laryngeal stenosis, there is a chance of deformed larynx. So how laser helps? Nowadays, I have seen you microdebrider with screamer blade. If the big lesion is there, it remove this. And by the laser, not only cutting, by fulguration, If the spot size is bigger, it only evaporates some tissue. And in pediatric patient, it is a good instrument, especially for the laryngeal wave, capillary hemangioma, subglottic stenosis, laser chordotomy, and in a bilateral vocal cord palsy, sometimes Kashima, erythronoidectomy, and posterior chordectomy, laser is an important source. Even early laryngeal cancer, especially the growth, T1A, T1B. Nowadays, intraoral laser surgery is one of the curative surgical mode. This is a YAG laser. Ablation, palliation of obstructing arterial bronchial lesion, esophageal lesion, removal of malignant tumors in oral cavity, obstruction of tracheobronchial tree. So our experience is mainly in tonsillectomy. We are using in mainly vocal cord lesion, early laryngeal cancer. We are working in the epithelial lesion, basically vocal cord polyp, even papilloma, using the laser. But the skin surgeon using in the pigment dermal lesion, otologists, they are using on the division stepidotomy. Limitation, of course, in laser, there is some sort of thermal injury. Most commonly used in our practice in CO2, neodymium, YAG laser. Laser photoresection of obstructive ear lesion, I will see you later. In congenital disease, especially laryngomalacia, it is a very important operation. Because in laryngomalacia, it is not treatment by conservative treatment, but there is an omega layering, and there is a softening of tissue on the epiglottal fluid. By carbon dioxide blood, just to remove that mucosa, the child will take a very good breath. Yes, in dysphonia, plaga ventricularis, laser is an important ornamentum. Some of the chronic conditions, especially Rinke's edema. Somebody says it is the smoker's edema. You got some of the patient. Laser fantastic. No need of excision, only incision and evacuation with the fluid is enough. You can give it a good voice. Ulceration in dermal laser gives benign laryngeal leukoplakia. This is only evacuation or fulguration, leuko good answer. Even you can take biopsy, excision of early malignancy in nose. Yes, especially from the allergic rhinitis. Nowadays, people are using the both diode laser and carbon dioxide laser. Some use this for nasal polyp. Dacrocystorhinostomy is a very important, very good time-saving surgery by the laser. As it is a very minimal invasive surgery, minimal bleeding, minimal postoperative edema and crusting, ambulatory surgery, cost-effective. Luminous laser for dividing scar tissue, exposing the malleus, especially in the otosclerotic patient, resecting the distal third of the malleus and malleus fixation, vaporization of the malleus sclerotic foci. In tympanosclerotic, easily we can whip up if someone is equipped with this surgery. In obliterative otosclerosis, especially why the laser is used, it vaporizes a fenestra in the foot plate regardless of its thickness or degree of fixation, because by scanner mode we can fix, the fixity by CT scan other, so the chance of inner ear trauma is minimum. If there is a chance of inner ear trauma, there is a chance of sensory hearing loss. And overhanging facial nerve, you can easily save. Conventional scapulotomy and curved perforator redirect the carbon dioxide laser beam. Now the people are using CO2 laser in scapulotomy operation. And cochleostomy, laser cochleostomy, inserting the electrode of cochlear implant, effective on ossified cochlea, especially where there is ossification, then laser is a good ornament area. Turbinate reduction, already I have thought. On the submucous, it reduces the swelling capacity and secretory function of the turbinate. If you use the laser, you will see, or if you use the diathermy or electrocautery, you think the postoperative edema will less, nasal blockage will be less. So you can choose a laser. Now, in laryngology, what we are doing in supraglottic stenosis, in glottic air stenosis, in bilateral recurrent paralysis, in supraglottic stenosis, because it is very difficult to touch this area. you have to go through the laser either by the beam or by the diode laser. And only if there is a clotic web, easily you can cut it by the knife, but there will be bleeding. There is a chance of postoperative edema. Again, there is a chance of granulation tissue and chance of addition more. But if you, by a wide area, you can cut by the laser, by the carbon dioxide laser, sometimes you not need the airway stent. So glottic airway stenosis in subglottic stenosis, sometimes it is very difficult. Yes, all those are equipped because there is some problem with the anesthesia and there is a safety measure you should take. I will talk to you later. But cut should be in a subglottic stenosis crisscross manner and use the things, either tissue or something. In bilateral recurrent laryngeal palsy, Kashima, one of the procedure by cordotomy. Sometimes somebody does the posterior cordectomy, some use erythroidectomy, some use posterior erythroidectomy in both sides. You know, it has other than thermal photochemical effect, transfer of light energy to chemical energy. Photons from laser have sufficient energy. How the things cut? When you heat the tissue, there is an increase of temperature. If the temperature is more than 100, there is some sort of protein degeneration, both intra and extracellular fluid. But for carbon dioxide laser, this laser energy absorbs in the fluid as well as the blood, other area. It is absorbed in the chromophore and the retina. But if the patient, during surgery, you should think of the patient, the eyes should be closed, but the chance of corneal injury, laser injury in that case. Transfer of heat into the tissue. Absorption of photon energy produces a vibrational excited state in molecules. Denaturation or destruction of the tissue. Because how it works? By photocoagulation, irreversible necrosis without immediate destruction of the tissue. Tissue will be eliminated, and by photovaporization, loss of substance.
আর একটু আলমগীর স্যার আনমিউট করলে ভালো হয়, মিউট করলে ভালো হয়। আলমগীর স্যার একটু মিউট করেন স্যার।
What are the injuries? Yes, injury, ear injury, retinal injury, and even there is maybe blindness, both for the operator and the patient. So you should be very careful what we are doing. So there should be maybe superficial injury, maybe deep burn. Penetrating burn produces a permanent damage. So cornea transplant for DPR may be required. So you should think, even ultraviolet sunburn can cause the injury. Because you have seen the erythema in a scan radiant area, photochemical effect on skin epithelium. So ultraviolet delayed effect, accelerated skin aging, skin cancer by sunlight can cause this protection. Thermal skin burn caused by the thermal effect on skin epithelium. So both laser and the normal light source sunburn can cause the injury, but laser injury is more. Why you are thinking of the hazardous? Because the lasers we are classified in the class 1, 2, 3, 4. Class 1, 2, less hazardous. So, but class 3, 4, if there must be a danger sign before we're going, danger sign, because these view goes in any area you have seen, it can injure both the skin, epithelial, deep tissue, eye, cornea. So this is very dangerous. When you see the danger sign, some areas going on, it should not enter without the precaution. So the operation theater could be equipped with the danger sign when the operation is going on. So there should be dedicated operation theater. There should be dedicated anesthetists for this. What is the laser safety? Why the safety standard is important? Very important, because it can be done both under local and general anesthesia. It's better to avoid the local anesthesia. Though dermatologists are use it under local anesthesia as only the superficial area is done, but there is still the chance of burning of the tissue and the complete roll of tissue by evaporation. But we are doing otolaryngology preferring under general anesthesia. Anesthetists should be equipped of this substance. So what the things we should know? We should know about the anesthesia technique. Anesthesia, what are the things? As we are using the endotracheal tube, tuft endotracheal tube, either rubber or Portex or Shelly made, or PVC made. These are all chance of ignition is more by the laser. So what to do with the anesthetics? They should think for the laser safety. Laser safety, many things we are doing with the tube. Because in our country, yeah, danger, where there is a danger side, we should be very cautious, very cautious. So there should be engineering control, there should be administrative control. So intra-beam protective housing, interlock protective housing, service access panels, key control. First, who use the laser? He should see where the laser machine key, because immediately you can stop the key. So you should know where the key is. Not only you should be mainly acquainted with the anesthetist or nursing supervisor or nurse or your assistant, they should know. So generally, if the proper double cup anesthetic laser tube is not available in our hand, then what to do? We are wrapped the endotracheal tube. Wrapping is sometimes dangerous. So wrapping size of the tube is changed. There is a chance of injury to the vocal cord. So somebody is not preferring. But before doing, both for the surgeon, anesthetic, assistant, eye protection should be must. Ensure that appropriate laser protective eyewear must be owned in the laser environment. You should not be very much reluctant before doing this, because there may be a chance of injury to your cornea. So proper eyesight eyewear, there should be multiple wavelength according to the laser. There are different types of eyewear is used. So for black or normal eyes, for commercial laser is enough. For KTP, it should be the reddish one. For NGA, it is a greenish one, because color vision effect, laser filtration, break resistant, fit and comfort. To avoid electrical hazard, barrier system for the anesthetic contact. Why? You should think, you should not keep your hand, when the laser beam uses a joystick, you should be avoided from your fingers and other area from the area, even sucker tube, because there is a chance of burning to the any area. So what's proper anesthetic tube? Anesthesia is introduced the endotracheal tube. If there is a cuff, how you inflate the cuff? You should not inflate the cuff with air. Air is full of oxygen. So accidentally, the cuff beam can injure the cuff and there is a firing. So better, the cuff should be equipped with the normal saline. It's better with the colored substance, gentian violet, blackish one. By this here, if there is any leakage, you can see there is a leakage of bulb. The thing is that in this way, how the things can be. Before any surgery or flaring, nowadays, the laser surgeons advocating, keep the laser, put some of the cotton hose in a cold water or oil in laryngeal surface in the vocal cord for some period, 2 to 3 minutes. Or if you don't do it, use the protective laser tube. Use some of the cotton soaked with gentian violet, placed with cold water under it, both behind it and at the side. Same, the patient's face and mouth should be covered with a wet gauze piece or mop. So one thing, so this is one thing. Yeah, that should be warned. There is a electrical hazards maybe going on. Other than electrical hazards, what are the things? Because in ADJ there is a fume. This fume is also dangerous. What the fume? Because this fume is from the normal tissue evaporation. This fume will sometimes not making disease. So there should be proper evacuating system in the anesthetic room. In the operating room, there is a dedicated room. The proper evacuation section should be done. To prevent fire, use flame retardant material wherever possible. To reduce the use earplug and muffs. To minimize collateral plasma radiation, install effective shielding. Increase distance between the radiation source and the personnel. Reduce the exposure duration. There can be explosion. Lamps and capacitor bank shall be enclosed in housing which can withstand the maximum explosive pressure resulting from component. One of the things, you are only keeping the water or normal saline. If there is a fire, use the normal saline. Not only this, the carbon dioxide and other things for controlling the oxygen is important, because it's very dangerous, a laser burn. So we have got very PT experience of laser burn in our patient. So some should think of the laser, because as this is very compressed guard, we are working. Laser dyes and solvent. To minimize exposure, laser generated airborne contaminant. Avoid recirculation. So vaporized system there, appropriate PPE should be worn. Laser process may be isolated. Now the people are using PPE for corona, but actually laser surgeon is using PPE and proper mask. Proper mask should be read. Disinfect, sterilize the working area of PPE immediately after biomedical application. So laser safety is very important. Use improper laser protective eyewear. Place reflective object into or near the beam path. Alter the beam path. Bypass interlock. Turn on laser accidentally. Turn on laser beam accidentally. If accidentally there is a fire, use the oxygen. Stop oxygen anesthetic. Anesthetic to stop the oxygen, and assistant or surgeon stop the anesthetic laser machine. If there is a chance, there will be a chance of minimal power of energy. For laser, good surgeon, they're using the minimum watt, because 1 to 2 watt is enough, especially now in the carbon dioxide watt. Don't go for 7, 8 watt. If there are bomb, the cutting error watt should be your. Terminate laser beam with the beam trap. Get hands-on training for each laser. Follow standards. Laser surgery differs from conventional surgery. How? The lack of feedback. Surgery is undertaken with a free beam or with the beam being transmitted via fiber withheld in the near contact position, where the surgeon uses the third hand. So malignancy, how he can feel the intubation? An experienced surgeon, by using the sucker tube, he can understand there is the intubation, how much there. And another thing, third thing, say there is a epithelial lesion, vocal cord polyp, vocal cord papilloma. What the surgeon will do? Surgeon is use some water or steroid underneath the mucosa, pull the polyp papilloma in such a way there is a gap between the vocal cord ligament and the fiber, and use the laser in this area. By cutting, by exploration, by evaporation, in that case, there will be less injury. And why the carbon dioxide laser is important, especially in the vocal cord papilloma, you can see, or polyp, you can see there is some minute blood vessel. So chance of recurrence is more, there is the blood supply is more. By the carbon dioxide laser, when you see the dilated blood vessel, only you can spot on that area. So the blood supply will be jeopardized. Chance of recurrence will be less. So localization target, hard and tactile, already I told. The experienced surgeon can be. Most important, your OT should be equipped with the suction, evacuation of smoke. I've seen our laser surgeon is using a second nozzle, using the laryngoscope, one for the light scope. There is another fenestration. They use the sucker on that fenestration unit. In that, evacuation is so will go very, very easier in that case, because there will be a darkening of the area. Depth of evaporation results in immediate loss of tissue. However, there is also delayed loss due to the irreversible thermal damage. So vaporization or excision, and depends on the which tissue, on which pathology we are equal. Other laser surgery, atmospheric contamination, perforation or a vessel structure. Sometimes there will be bleeding will more if you struck the vessel, because it cannot block more than 5 millimeters. In that case, you may need the diathermy. How a diathermic use? There are so many second nodules equipped in this area. In that point, chance of embolization, inappropriate energy transfer. But what anesthesia will be the given? Sometimes it is very difficult to use the endotracheal tube anesthesia. Sometimes when you working on the vocal cord or below the vocal cord, tubeless anesthesia sometimes needed. Sometimes anesthesia will total intravenous and no tube. Sometimes they should use the applique method. Sometimes jet ventilation is very important. So anesthetic should know the jet ventilation. But there are so many complications with the jet ventilation. In our patient, we have got the pneumothorax. If the one lung is there, the pressure, jet ventilation pressure will be chance of pneumothorax is more. So you should think for this area, the anesthetic should know and equip with that what complications can be, laser can have, chance of gas embolism, inappropriate energy transfer, high patient medical, patient endotracheal tubes can turn into power. very dangerous endotracheal tube fire. We have got an experience. We immediately stop the oxygenation, immediately stop the use fire. Fortunately, the patient was all right, no problem with that. So it worldwide it is 0.5 to 1.5%. So proper anesthetic tube should be used, proper machine should be used. Cuff should be inflated with the water, not with the air. The cuff should be, face and other areas should be covered by the wet gauze place, and the person should be equipped with the, otherwise if the chance of ignition, then there will be dangerous. So reduce the flammability on the endotracheal tube, protection of the endotracheal tube, using metallic venturi jet ventilation cannula, use intermittent apnea technique, reduction of oxygen content, wrapping with mustard, muslin, coating with dental acrylic, wrapping by, we are using aluminum foil, copper foil, is better weight with alcohol, protection of an endotracheal cuff, completely cover the visible cuff with moist and cotton pledget, cuff inflated with saline. Methylene blue cuff is better. Disadvantage of wrapping, no cuff protection, adds thickness to the tube, not an FDA approved device, it device in third world country. Protection varies with type of metal foil. Adhesive baking may ignite, may reflect laser or onto non-targeted tissue, rough edges. So somebody should think what it is. I like to sorry for inconvenience. Next. Before operation, we should be equipped with stereoscopy. Yeah. So you can see the wavelength, the vibration of the focal pulse. Because my previous video was not working, that was a bilateral abductor pulse was showing after a thyroid surgery. In that case, you can see the vibration of the focal pulse. This is a video strobe. What is the difference between the video laryngoscopy and stroboscopy? Video laryngoscopy, we can only, because you know the human lethia perceive only 5 images per second, but vocal cord raises more than 100 cycles per second. Video stroboscopy can range all the 100 cycles, even the periodicity. Another patient with a, after thyroid surgery, the patient with the unilateral vocal cord palsy. What to do, we see the vibration on the second vocal cord. In that case, laser is not important, because in that case, we are using for fat injection or thyroplasty. This is mainly the layers of the epithelium. You should know why it is important. Important because there is a superficial layer, the intermediate and lip layer produce the vocal ligament. So before doing any surface of the epithelial surface, you should not injure the vocal ligament. If there is injury to the vocal ligament, there is some sort of fibrosis. If you injure the muscle, obviously there will be fibrosis. So in any epithelial lesion, you only injure the superficial texture. By carbon dioxide laser, they both thermal effect, injury to will be the less. So we prefer the laser surgery in this case. This is another patient who is using, showing it is the beam. Beam is a bigger area. This is a patient with a stenosis, subglottic stenosis. By the cutting the beam area, how it works. Another patient with subglottic stenosis, very difficult, especially after laryngotracheal stoma. We got a lot of patient comes with a tracheostomy and with a laryngotracheal stenosis, especially in the vehicle injury. The women are using the urna in their neck, and there is a shallow machine or other injury. There is a trauma, and that case is very difficult in these cases. They cannot speak, they cannot breathe. In this area is very difficult. So in that cases, what to do? You can use both the diode and carbon dioxide laser by a crisscross manner. Yes, you have seen the work is done beautifully. There is a T-tube is through the incision is given on. T-tube is placed in place. But especially in the tonsillar cancer resection, why we are preferring nowadays in the patient with a, we are not doing the PET CT scan in every cases with unknown primary cases. There is a neck nodes or metastatic neck mass. So we all, after all investigations by CT scan and illumination endoscopy, triple endoscopy, bronchoscopy, laryngoscopy, no lesion is isolated. So in that cases, now we prefer the tonsillectomy in both sides, taking a much of tissue around the tonsil, especially in the area. And in 30% cases, we have seen the primary site may be tonsil. And in last 15 days, we are casing 2 cases, and 1 is positive. The tonsil was looking on finger palpation, there is no disease. So the anything you can use by simple tonsillectomy, by dissection method, by coablation, by other method, by bipolar diathermy. But we prefer carbon dioxide laser or diode laser in use. There is bleeding will be less, and taking a lot of tissue in that cases. In that cases, yes, this is a tonsillectomy. That should be bilateral tonsillectomy. And this patient, yes, this is a patient how, but you'll see there is a laser tube is there. If the laser tube chance of ignition is less, in that cases, is a proper laser tube with a cuff. So anesthesia are a bit reluctant. If you use the wrap tube, you use the using that to not hit the area, and that cases. Yes, this patient is a bilateral abductor palsy. So nowadays, patient with a tracheostomy is very difficult. Still, we are getting a lot of patients. Before surgery, somebody used to the 70-degree laser, see the subglottic aspect, if anything is there. This is another patient where the early glottic cancer or carcinoma in situ. Carcinoma in situ, in that case, is, yes, chordectomy is the answer. You can do the partial chordectomy. There are 4 types of chordectomy according to the disease extension. Even T1B lesion, you can go to the onto the introgression on the other side. And carbon dioxide laser is one of the important ornamentarium. Because if you can do it by the diathermy and others, in that case, charring will be less, more. In that case, their postoperative edema will be more, chance of postoperative edema, patient need tracheostomy. And if they use the laser in that area, there is a thermal injury will be less, postoperative edema will be less, and even voice quality is good. So in early laryngeal cancer, especially T1A, T1B glottic growth, now the paroral or transoral CO2 laser is an effective curative treatment. Now it is a curative treatment for the laser surgery. So our new generation, we are saying the boys should be acquainted how to use the laser, how to use the carbon dioxide laser, what precaution you should take. So normally beforehand, before the surgeon the laser, one should be equipped with the primary, the normal surgery. They should, for tonsillectomy, they should know how by dissection method, still the dissection method is the best method, or by thing you are using laser or diathermy or coblation, the thing you are used. These are all ornamental. This is not the alternative. But for cancer treatment, yes, radiotherapy has, other than this treatment, you can give the radiotherapy. For radiotherapy, there will be a chance of voice here is less, and radiotherapy is more costly because CO2 laser is cost effective. So we are grateful to, first of all, to my mentor and Professor Alauddin. He helped us. First carbon dioxide laser, he and Professor Tahir sir gave us, but that laser was in our department, the Korean laser. Now we have got the luminous laser, and this luminous laser, this is costly. That was, we got it during Professor Pran Gopal sir period. This is a scanner mode. This is a bilateral abductor pulse. You can see how we can do the posterior chordotomy. Yes, posterior chordotomy, beautifully you can do the posterior chordotomy. Sometimes you can repeat the process twice or thrice. Sometimes a posterior chordotomy, part of the vocal cord tissue is removed. Sometimes to take part of the erythenoid, sometimes total erythenoid is done. So nowadays, the bilateral abductor palsy, we should think. So still, the tracheostomy tube with a speaking bulb, best alternative. But it's very, tracheostomy is somewhat hazardous complication. By simple chordotomy, yes, you can give the good area. Even the patient speech is also good. Patient can hear. Nowadays, the people are thinking the reinnervation technique, yeah, by encephalocele, by other nerves, by the phrenic nerves. So in bilateral abductor palsy, we are getting a lot of patients, especially after thyroid surgery, with bilateral surgery. Prevention is better than cure. We should think before surgery, we should know the anatomy. We should not injure not only the recurrent laryngeal nerve, we should not injure the superior laryngeal nerve, because I have got the very experience in Goa, India, where I have shown 37 patients with bilateral palsy. And then the Paul Castellanos was very happy seeing he clapping hand, but during a cocktail time, he was asking Dr. Tarafder, you are doing a lot of surgery, fantastic, 37 surgery, but your patients are so unfortunate. So I am telling our patients should be unfortunate. We should be unfortunate. So things should be twice before doing thyroid surgery. You should not injure the recurrent laryngeal nerve. You should not injure the recurrent laryngeal nerve. You should not injure the superior laryngeal nerve. If you keep the parathyroid, not only the surgery should be the art. So things should be goes in this way. These are some of the patients you see. We have got the total stenosis. This is a laryngeal web. These are done in our center. In a total stenosis, I have seen one of the patient using the T-tube in the patient. And this patient, we are using the tantalum kill. We have got the very beautiful team and surgeons, Professor Babur, Saudar Idris, Wahed, a group teams. They are doing nice work job. We done more than 50 patients. Now the patient, it is not the dream. It is not necessarily the patient, you refer the patient to outside. This is a T-tube, but now they think it should be cheaper. Silicon T-tube, silicon umbrella kill, it can be used. How the T-tube is placed. This is a patient 11 months after decannulation. Patient can speak. This is the 8 months after decannulation. This is 4 months after decannulation. So in this way, I think now the corona period is going on, for God's sake.
Sound আসে নাই তো কামরুল ভাই। কামরুল ভাই মিউজিকটা আসে নাই। আপনি এটা আবার শেয়ার করেন ইয়ে দিয়ে
সাউন্ড আসে নাই?
না সাউন্ড আসে নাই
সাউন্ড আসে নাই,
ওইভাবে করেন
Responsibility to stop it from exploding. So please just wash your hands. Don't touch your eyes, your nose, your mouth. Social distance, avoid the crowds. Fight against the corona. Practice good hygiene and keep your personal space clean. Respect the social distancing. Fight against the corona. Against the corona. It's like the flu, but it's so much more cruel. And it's super contagious. Yeah, it's tough, but we all play a part. We'll prevent it together. Ooh, and now we've gotta stay alert. Stop it from getting worse. It's our responsibility to stop it from exploding. So please just wash your hands. Don't touch your eyes, your nose, your mouth. Social distance, avoid the crowds. Fight against the corona. Practice good hygiene and keep your personal space clean. Respect the social distancing. Fight against the corona. Not an Asian, black or white. The corona is colorblind. Together we can win the fight. Fight against the corona. Stay ready today, and tomorrow will be okay. Together we can win the fight. Fight against the corona.
হ্যাঁ, পয়লা বৈশাখ সমাগত, নববর্ষের শুভেচ্ছা। আজকে আবার ওয়ার্ল্ড হেলথ ডে, and আজকের হলো বিল্ডিং এ ফেয়ারার এন্ড হেলদিয়ার ওয়ার্ল্ড। থ্যাংক ইউ অল, থ্যাংক ইউ।
আসসালামু আলাইকুম।
শেয়ার করে দেন
কামরুল স্যার, এই শ্রদ্ধেয় খুরশেদ আলম মজুমদার স্যার কি একটু অনুরোধ করব? স্যার আমি তো একটু আরেকটা মিটিং এ যাব, যদি আমি দুটো কথা বলে যদি অনুমতি দেন আমি চলে যাব স্যার।
শিওর
স্যার
শিওর কামরুল ভাই ইয়ে করেন ওই
কামরুল স্যার
করতেছি,
আপনার স্ক্রিন শেয়ারিংটা ইয়ে করে দেন।
করতেছি।
Kamrul sir, thank you very much for
Sir.
your excellent deliberation of the speech. Excellent. It is very much helpful for all the students, even also all the postgraduate, even for the teachers also. আমি এখন সবাইকে অনুরোধ করব, যারা আমরা সিনিয়ররা আছি, যারা আমরা নীতি নির্ধারক পর্যায়ে আছি, আমরা যেন আমাদের এই লেজার ফ্যাসিলিটি বাংলাদেশের বৃহত্তর মেডিকেল কলেজ হাসপাতালগুলোতে প্রোভাইড করতে পারি, সেজন্য আমরা সর্বাত্মকভাবে চেষ্টা করব উপরের মহলে। কারণ লেজারের যে আমরা সবকিছু দেখেছি, সবকিছু সুবিধা দেখতে পেরেছি, সুতরাং আমরা চাই আমাদের ঢাকা মেডিকেল, সলিমুল্লাহ মেডিকেল, 8টি বৃহত্তর মেডিকেল, সব মেডিকেলে যেন লেজারগুলো ঠিকমতো ফাংশন করে এবং ম্যান পাওয়ার ডেভেলপড হয়। আমি স্যারকে অসংখ্য ধন্যবাদ জানাচ্ছি, আমাদের সমস্ত সিনিয়র জুনিয়র সবাইকে শুভেচ্ছা জানাচ্ছি। আমরা সবাই ভালো থাকি। খুরশিদ স্যার,
কুমিল্লা মেডিকেল সহ
বিদায় নিচ্ছি। হ্যাঁ, সবাই দেখা হবে, আমার জন্য দোয়া করবেন স্যার। আসসালামু আলাইকুম।
কুমিল্লা মেডিকেল থাকার খুব কাছে, কুমিল্লা মেডিকেল সহ।
হ্যাঁ, সব মেডিকেল স্যার, অবশ্যই স্যার, সব মেডিকেলে। জি,
থ্যাংক ইউ রমি। আমি এখানে এইটুকু বলতে চাই, থ্যাঙ্কস প্রফেসর কামরুল হাসান তরফদার ফর হিজ ভেরি এক্সিলেন্ট এন্ড elaborate presentation mentioning all the aspects of the our laser used in otolaryngology, and it is really an art, because laser in otolaryngology minimum 15 days needed to have a experience and to know about this. And it is the art, it is the way of presentation Professor Kamrul Hasan Tarafder has presented us to give an idea. And this will be very useful for our students, our learners, as well as the senior people who have been with us, who are handling and beginning to handle this laser in otolaryngology. And now I will request our panelists. Before going to the panelists, I like to mention everyone that today's our scientific partner is Incepta Pharmaceuticals, who have helping us to perform this and continue this our program. So, you know, we are on the, this is our 17th program, and next program will be examination of a case, examination of a clinical case in that we used to do in final FCPS and final MS examinations. Now I will request Colonel Bashiruddin, Colonel Basir Ahmed to comment and mention his observation on laser in otolaryngology. Colonel Basir. Colonel Basir, please unmute and please unmute.
Assalamu alaikum, sir. Sir, thank you very much for inviting me as a panelist here. Kamrul Hasan sir has given an excellent lecture. He has covered all aspects. Nothing is left from starting from the physics to the clinical aspects of the laser in otolaryngology. One thing is that in so many centers we have the lasers, but there is a fear of using the laser. And there is some things there that sometimes that we are very reluctant on the precautions for the use of the laser. So I will mention only these two things. There is nothing to be feared. It's a very good and excellent equipment for different types of surgeries. There is a wide range of safety, but if we can maintain the safety measures, there is no chance of any hazards. Only in one point I want to add with Professor Kamrul sir, there is for the recurrent respiratory papillomatosis, different centers, they are preferring the microdebriders. They have a comment on that the vaporization may, it can settle the viruses in the lower parts of the lungs, of the tracheobronchial tree. In AIMS, they have taken the project, they are comparing between the effectivity of the microdebrider and the laser, carbon dioxide laser, in recurrence of the recurrent respiratory papillomatosis. And they have given a conclusion that is microdebrider is more safer. That is the only point. Otherwise, everything is excellent, sir. Thank you very much, sir.
Thank you, Colonel Basir, for your excellent comment. Now, I like to request Professor DGM Akaiduzzaman, the Vice Principal and Head of the Department of ENT in Midford Medical College Hospital for your observation and comment, please. Professor DGM Akaiduzzaman, please be unmuted and pass your comment.
Thank you, sir. Today's presentation by our respected Professor Kamrul Hasan Tarafder was excellent. He covers all aspects of lasers. Actually, laser has revolutionized the treatment of particularly larynx, trachea. It has revolutionized. Laser has also has different types of laser has also has role in ENT, in ER, nose, throat, even in the skin, eye, and even in the laser pointer, laser printer, laser door control, even different types of use of lasers is there. But laser has revolutionized the ENT, particularly of the larynx and trachea. But using the laser in this area is very critical. So how we can use that is important. How can we give the gas? How can we use the endotracheal tube? And if we use the endotracheal tube, the space becomes reduced. So use of laser would be limited. So in that case, how we can give the oxygen? It can be given by the nasal route, by nasal cannula, or by the endotracheal tube with aluminum foil, or dedicated endotracheal tube, or intermittent ventilation or jet ventilation. In this way, we can use the laser in the particular area. The advantage of laser is it can be used in the definite point, and it has minimal injury to the site tissues, and it has very much limited minimum edema and pain in the postoperative period. So these are the advantages, but the precautions of the using the laser is very important. So everybody should using the laser, from the doctors, nurse, everybody should be cautious in using this laser. And during the using laser, the door, the room, everything should be kept in that way. So thank you everybody for joining this program. Thank you.
Thank you, Professor D.J. Makaidujaman, for your very illuminating, instructive suggestions and your ideas and sharing your knowledge. Now I like to request Professor Sheikh Hasanur Rahman Babar. Professor Sheikh Hasanur Rahman, please, your comment. You are a real worker in the field, and please try to be short, mentioning your points.
Thank you, sir. শোনা যাচ্ছে, স্যার? Sir, many congratulations to Professor Tarafder sir for very nicely presenting a very unusual or uncommon topics, not unusual, rather uncommon topics for us. Actually, for his enthusiasm, laser has come in not in BSMU but in Bangladesh, rather I can say in Bangladesh. First came to BSMU for his enthusiasm, for his encouragement, and for his endeavor, and that was followed by other institutions like in Dhaka Medical College, Mitford, in some other private institutes. Actually, initially we started using laser, carbon dioxide laser and diode laser. KTP is also there in BSMU. The first, actually carbon dioxide is called the workhorse in the field of otolaryngology. Carbon dioxide laser has versatile use in otolaryngology. Ear, nose, throat, oral cavity, oropharynx, in sleep surgery, in airway surgery, everywhere. So, and initially we started with Korean one, sir mentioned. Actually, the best one is Luminous one. It has many advantages, and we have seen that some spot, aqua spot, যেটা আমরা spot use করি, rounded একটা spot use করি আমরা low grade laser গুলোতে আমরা use করি, but in Luminous or advanced laser সেখানে aqua spot, aqua blade, আমরা linear, curvilinear, rounded, different types of laser shape আমরা use করতে পারি. So shape, size, and depth precision. Depth also important. By scanner system, we can use depth, single depth, double depth, triple depth. And depth means এখানে আমরা একবার লেজার হিট করে কতটা ডেপথ টিস্যু আমরা ফালগারেশন or কাটিং করব। তো সেখানে লুমিনাস লেজারে একবার যদি আমরা হিট করি সেখানে 0.005 মিলিমিটার টিস্যু বার্ন বা ফালগারেশন করে। তো so we can measure the depth of the tissue, targeted tissue. For example, in case of leukoplakia or carcinoma in situ, আমরা আমরা আন্দাজ করি যে আমরা কতটুকু ডেপথ টিস্যু আমার নিতে হবে, সেইভাবে আমরা ডেপথ ঠিক করি, অথবা আমরা কতবার হিট করব, অথবা ডেপথ মেজার করা যায়। আমরা আমাদের ওই কম্পিউটার স্ক্রিনের মতো সেখানে আসে সিঙ্গেল ডেপথ, ডাবল ডেপথ, আমি কত ডেপথ নিতে চাই, ওইভাবে মেজার করেও টিস্যু বার্ন করা যায়। আর একটা জিনিস যেটা শেপ অ্যান্ড সাইজ অফ দা, স্যার হয়তো এত অল্প সময় স্যার এত কিছু ইয়ে করছেন, আসলে আমার মনে হয় কিছু কিছু জিনিস আর একটু মেনশন করলে মনে হয় ভালো হতো, কিন্তু টাইম শর্টেজের জন্য, আর স্যার অনেকগুলো অ্যাসপেক্ট কভার করতে গেছেন, তো সেই জন্য আমার মনে হয় দুই একটা জিনিস অ্যাড করলে আমার মনে হয় করতে পারি আর কি। যেমন আমরা যখন একটা স্পটকে স্যার নির্ধারণ করি, তো সেখানে যতটা হিট বা এনার্জি ডেলিভার করবে, ওই স্পটটাকে যে আমরা ডিফোকাসিং করি আর একটু বড় সাইজ করে দেই, তখন হিটটা একটু কম হবে। যেমন আমরা স্যার লিউকোপ্লাকিয়া ফালগারেশনে সেখানে আমরা স্পটটাকে বড় করে নিই, লার্জ এরিয়াটাকে কভার করি, পুরো মিউকোসাটাকে বার্ন করে জাস্ট আমরা রাবিং করে ওই মিউকোসাটাকে রিমুভ করে দিই আর কি স্যার, এরকম একটা জিনিস। তো এখানে এটা হলো স্ক্যানার সিস্টেমের সুবিধা। স্ক্যানার থাকলে বা হায়ার গ্রেড অফ কার্বন ডাইঅক্সাইড লেজারের সুবিধাগুলোর কথা আমি বলতে গিয়ে কথা বললাম আর কি স্যার। আর এখানে আরো ফায়ারের কথাটা আমি ফায়ার ছাড়াও আমরা যেটা বলতে চাই স্যার, আমাদের সব ইনস্টিটিউটে লেজার দরকার, এবং এট দ্য সেম টাইম আমাদের ট্রেনিংও দরকার। সবাই আমরা সবকিছু করব এমন না, বাট ডেডিকেটেড থাকতে হবে দুই একজনকে, যে আমি লেজারে কাজ করব, আমি এরওয়ে সার্জারি করব, আমি স্লিপ সার্জারি করব। আমি সবকিছু শিখতে চাইলে আমি পারবো না, এটা সম্ভব না। সবকিছুতে স্পেশালাইজেশন করা কোনো মানুষের পক্ষে সম্ভব না। তো সেই জন্য ইনস্ট্রুমেন্ট হ্যান্ডলিং ইজ ভেরি ইম্পর্টেন্ট। লেজার হ্যান্ডলিং, আমরা কিভাবে কার্বন ডাইঅক্সাইড লেজার হ্যান্ডেল করব, কিভাবে ডায়োড লেজার হ্যান্ডেল করব, এই জিনিসগুলো আমাদের যারা কাজ করব তাদের অবশ্যই ট্রেনিং করা উচিত। নিজের চেষ্টায় হোক, ইনস্টিটিউশনের চেষ্টায় হোক, গভর্নমেন্টের চেষ্টায় হোক, আমার ট্রেনিং করে আমার ইনস্ট্রুমেন্টে হাত দিতে হবে, আদারওয়াইজ দেয়ার মে বি সাম ক্যাটাস্ট্রফি। যেমন স্যার বললেন যে ফায়ার যেটা হইতে পারে, সারফেস ফায়ার হইতে পারে, এয়ারওয়ে ফায়ার হইতে পারে। এয়ারওয়ে ফায়ার ইজ ভেরি ডেঞ্জারাস কমপ্লিকেশন। তো সেখানে স্যার যেমন বললেন যে কাফ টিউবকে প্রোটেকশন দেয়া, কটন সোকড, স্যালাইন সোকড কটন দিয়ে কাফকে প্রোটেকশন করা, কাফকে অ্যাডিকুয়েটলি ইনফ্লেট করা হয়েছে কিনা, এয়ার রিগার্জিটেশন করা কিনা, এগুলো দেখা। আর লেজার মেশিন একটা ইমার্জেন্সি সুইচ থাকে, ইমার্জেন্সি সুইচটাকে সঙ্গে সঙ্গে অফ করে দেয়া, স্যার বলছে অক্সিজেন বন্ধ করে দেয়া। ইভেন বলা হয় যে এন্ডোট্রাকিয়াল টিউবটাকে সার্জন টান দিয়ে বের করে ফেলবে, সঙ্গে সঙ্গে টান দিয়ে বের করে ফেলবে, পরে দরকার হলে আবার ইন্টুবেট করবে। দিস ইজ অ্যাকিউট ইমার্জেন্সি। তো এই জিনিসগুলা আসলে আমাদের জাস্ট মনে রাখতে হবে আর কি। আর স্যার এমনিতে ওই লেজারের ইউজ করতে গিয়ে বলছেন, ডিসিআর এর কথাও বলছেন। ডিসিআর এর ব্যাপার আমরা একটু স্যার ইউজ ঠিক আছে, বাট ডিসিআর এর জন্য লেজার ইজ দ্য ইকুইপমেন্টস যেটাতে রিকারেন্স রেটটা হাইয়েস্ট। আদার মেথডের থেকেও recurrence rate is highest in laser DCR than external DCR or endoscopic DCR. তো সেখানে হয়তোবা আমরা কনসিডার করতে পারি, টাইম সেভ হয়, বাট কমপ্লিকেশন ইজ মোর ইন লেজার DCR। আর স্যার তো সবকিছুই কভার করছেন, আসলে আমাদের আর তেমন বেশি কিছু আসলে বলারও থাকে না। তবে আমি অবশ্যই এর জন্য অনেক ধন্যবাদ দিই কামরুল হাসান তরফদার স্যারকে। উনি চেষ্টা করে আলাউদ্দিন স্যার এবং প্রাণগোপাল স্যারকে দিয়ে, উনি যখনই কোনো একটা নতুন প্রসিডিউর আসে বা ইয়ে করে, স্যার সবসময় নতুনের পক্ষে। নতুন কোনো ইনস্ট্রুমেন্ট আসে, সেই ইনস্ট্রুমেন্টটাকে আনার জন্য, ব্যবহার করার জন্য স্যার সবসময় সচেষ্ট থাকেন যে আমাদের ইনস্টিটিউটে আসুক, সারা দেশে আসুক, আমাদের দেশের সার্জনরা, আমাদের ছেলেরা ট্রেন্ড আপ হোক, এই ব্যাপারে স্যার সবসময় সচেষ্ট থাকেন। এজন্য স্যারকে অনেক অনেক ধন্যবাদ। থ্যাংক ইউ স্যার।
Thank you, Professor Hasanur Rahman Babar. I like to request Professor M.A. Matin for your comment. Professor M.A. Matin, for your observation and comment. Please unmute and pass your comment.
Thank you very much, Professor Tushal Majumdar, actually, and my respected teacher, Professor Kamrul Tarafder, for deliberation of this timely, really, hot topics of laser. The topics is very hot and exam oriented, and he covered all the aspects. Actually, I remember it was 1994 actually, the Royal College of Surgeons of Edinburgh, one question come up, the board questions, use of lasers in surgery. Professor Kadir was with me on that exam, but he was very nicely answer the questions, and he was just discussing the thing, the ledger. In those days, we didn't know anything about the ledger. They already started. Then 1996, I was in Ireland, so we started KTP ledger. So actually, ledger for the exam was a common of what he described is a huge, but for the students, you have to precisely, cut short the things for your exam, like what is ledger, what are the types of ledger, use of ledger in ENT, and what are the precaution. So in the 4 or 5 headings, very shortly you can answer the question. Now the thing is, as you know, in 2005 I was starting coblation, but in 2008 actually the cobbler 1 they stopped producing cobbler 1. So what to do? Then I bought diode laser in Bogra and Rajshahi division. So I was starting tonsillectomy because for the last 2005 since I am not doing any single tonsillectomy by dissection method, or the most of the time as a diode laser or coblation or whatever it may be. So diode laser is a fantastic. If you want to practice on that, it's fantastic for tonsil, thanks for tongue base, fantastic for sleep surgery, fantastic if you are trained with this diode laser, and also you can use on the larynx. We are lucky enough in Swiss Ortho Medical College, we have diode laser, we have carbon dioxide laser. Bangladesh ENT Hospital, we have carbon dioxide laser, diode laser, and also Bogra, I have diode laser. So we are using their lasers very frequently. And today's discussion is really for the students actually, or for the learner or beginner, they can exercise on the lasers. Regarding precaution, if you know, you don't need that much precaution. Precaution is in your hand because you're the surgeon. Even I am not only aluminum foil sometimes, but even for tonsil, for tongue base, I don't use even the precaution like that. I only put some soap ribbon gauze around the tube. So you don't need to burn the tube. So you're careful, you don't need that. But if you work on larynx, definitely you have to put the water for infiltration of the balloon, as well as you can use the aluminum foil. Otherwise, precautions okay. No, if you're careful, not that much. And laser is not a difficult job. It's very simple because it's a knife. Oh, it's laser. What to do? No, it's a simple knife. So it's a precise knife, bloodless procedure. So if your hand is controlled, you do it, no problem. So thank you very much, Kursala Mazumdar and your Kamrul Tarafder, sir.
Thank you very much, Professor M. Mateen, for your nice comments and giving idea about our Western world. Now I'd like to request Professor Firoz Ahmed Khan. Professor Firoz Ahmed Khan, sir, please pass your comments and observation. Please unmute and come with your video. Professor Firoz Ahmed Khan, sir, are you here? Yes.
Coming. Thank you. Thank you very much. Actually, Professor Kamrul, he covered all the things, all the aspect of the lasers, types of laser, and what are the complication, precaution, everything. But actually, because he is doing laryngeal surgery, so he shows more on the concentrate more on the laryngeal operations. And the use of laser in Bangladesh, actually, it is limited on the laryngeal surgery and oral surgery, maximum. So far I know, but our otolaryngologist and not yet, I think they started using laser in trauma or mid-layer surgery. Up to my knowledge, it is not, I'm not sure about it. Maybe it is not yet. Yeah. See, the problem is whenever some instruments come, there is enthusiasm of doing everything by the same laser. It happened before also. All the laryngeal lessons we are doing by laser. But nowadays, it has been proved that small nodule, small polyp or cyst, it can be better excised by the microlaryngeal excision. Only the malignancies and large tumors can be done by the lasers. And another problem, another problem. I'm not worried about the precaution and what are the things you have to take before doing laser, because whenever you are using an instrument, even if you buy a microwave, you have to read out the procedures, how to use it. Whenever you're buying a fridge, you have to read out the procedure. Whenever you're doing a laser, you have to know that the precautions should be outside and inside and tube and anesthesia. These problems before doing laser, everybody should know. So this is a no mistake here, no mistake here. A glass, these are normal thing. But problem is every year, suppose diode laser came, then Korean laser came, then luminous laser. It is difficult for us, like Bangladesh, maximum place, they are not capable to buy luminous laser. Though it is a just scanner type, just make it point, everything is fixed and do the surgery, very easy. What Babu told also, that Korean carbon dioxide laser and luminous carbon dioxide laser, far difference, far difference. And the more they develop the instruments, more the easier to do the operation. Okay. But I think, I hope in Bangladesh, laser will be available everywhere. And you cannot avoid advancement in the medical science. You have to you have to be with the development. Otherwise, you will be lagged behind. But we are lagging behind because of our financial crisis. So I hope the institutes and other private sectors also, suppose in my institute also, they are going to buy diode laser. After long discussion, they agreed. But I cannot buy a luminous carbon dioxide laser because it is very costly. But still, diode laser is cheaper, and as Matin told, oral cavity, anything, it can be better done with the diode laser also. So I hope, but not the least that Dr. Professor Kamrul, what he told today, he covered all the sides of the laser surgery and its complication. Thanks for his nice lecture, and thanks Khurshid Alam Mazumdar to keep me awake till night because I am sleeping earlier nowadays in this corona, coming earlier home, sleeping earlier because older man now. So, but today's lecture I was thinking, how can I stay 11:30? But now I don't know how much it is time. So thank you, Khurshid, for keeping me awake, and thank you everybody. Thank you.
স্যার আপনাকেও থ্যাংক ইউ সুন্দর লেজার শার্টের জন্য CO2 লেজার শার্ট
Thank you, Professor Firuz Ahmed Khan, sir, for your nice comment, keeping you awake. Now I like to request Professor Mahmudul Hasan to pass your very short comment on our laser descriptions and procedures that described by Professor Kamrul Hasan Tarafder. And after that, if Professor Nizamuddin Farooq is there still, has not left, I'll request him to get prepared to say something. Professor Mahmudul Hasan.
Thank you, Khurshid, for allowing me to say something in front of this learned audience. Thank you, Khurshid, Professor Kamrul Hasan Bhai, for a elaborate and very nice lecture. But I think this is a very wonderful instrument if you handle it. And what Professor Firuz Bhai told, that every instrument, if you use, you must go through the manual. Otherwise, you can do a very dangerous thing. Your laser is a very dangerous instrument also. If you don't know, you can do anything. Because in few years back, 2 to 3 years back, I know one center where when they are using laser, they are burned the whole of the trachea. So this is complications are happening, but you should know how to handle all these things. Otherwise, you should not do this. But laser is a very wonderful instrument. I am using in every aspect what Kamrul bhai already mentioned in DCR operation, in nasal operation, in laser laryngeal operation. One case I still remember is a young boy of 12 years old when he strangulated with a muffler by the machine. Then he came to me a few years back, I 8 or 9 years back in Sorati hospital. Then he has a 1 inch length stenosis in the trachea below the just subglottic region. Then I took him to the Sorati hospital, and there I recanalized his trachea and put a T-tube there. And after 9 months or 10 months, I just taken out, and he's all right now. So, but after 5 or 6 years, he again re-stenosed, and I sent him to Professor Babur to recanalize that thing. I don't know what Babur had done with this case, but that was a wonderful case I have handled with laser. But I think it's a very good instrument for the laser surgery. Very good instrument. You cannot compensate it with other instrument, especially the laryngeal stenosis and vocal cord and other lesions. So I think, but doing with a laser, it is very imperative to know how to handle it. Even when I was in Sahik, I used to do the stepedotomy. Even in Sarsolumula Medical College Hospital, I used to do stepedotomy with the laser. So I found it very, very necessary and very good for me to do all these operations. But one thing I must address to the don't pull the patient's money with telling the laser is a very special instrument and you are sucking the patient's money. I have seen a lot of patients who has just told that by doing laser surgery, they have, the doctors are earning a very sizable amount from their pocket. So this should not be. This should not be, because it's an instrument of the everyday use, and we should remember that the patients came to us, and we can use the latest model instrument, but don't sucking the patient's pocket. Thank you very much, Khurshid.
Thank you very much, Professor Mahmood Hasan. Professor Nizamuddin Farooq sir, can you pass any comment? Can you hear me? Professor Nizamuddin Farooq.
Thank you very much. I did. And Professor Mahmood Hasan, I can see you after such a long time.
Thank you, sir.
And thank you so much. And Khurshid Majumdar, thank you so much, Professor. And especially, I admire Professor Tarafder. He just passed. He just presented his paper flawlessly. I just want to add certain things. Instead, in the Western, in the middle surgery, they are using argon only because of the fact that carbon dioxide laser, it carbonizes the tissue all around, and also the production of heat goes from 100 to 300 degrees centigrade, and it causes a lot of disadvantages. And on the other hand, if we use the argon in the middle ear only, I say, in the middle ear, in the middle ear, you can always be safe. But the carbon dioxide, the surgeon must be very, very cautious, only because of the fact that there may be a combustion because of anesthetics, gases, and carbon dioxide heat. and isobaric production of the isobaric gas. And these are the problems of carbon dioxide. So thank you so much and good night, all of you.
Thank you, sir. Thank you very much. Now I like to request pass very simple comment rapidly, Professor Manwar Hussain. Professor Manwar Hussain, please
Yes.
pass a comment.
Thank you very much, Khurshid, for your very nice topic to select to discuss among the teachers, I mean the senior teachers and the students. Actually, first, when I saw the laser first, when I was in the institute, I mean the National Institute of ENT, it was purchased from the government source, and it was purchased after purchasing this instrument and installation in the ENT Institute.
Fix your light. I cannot see your face.
Oh, okay, okay, okay. Can you see? Oh, okay, sir. Okay. Actually, what I have seen and what I have done by the laser, that is the carbon dioxide laser. First, I saw the laser, I mean the carbon dioxide laser in the institute, and I did very small operation, that is the vocal cord polyp and the vocal cord nodule. Before doing this surgery, I practiced this laser machine over the chicken meat. First of all, what I want to say, before doing any surgery by laser, you must acquainted and you have enough knowledge to operate this laser machine. Otherwise, it will be very dangerous to the patient and also the surgeons. So it is a very good instrument for excising the small lesion. My comment, only one, that is if it is a big one. Laser tonsillectomy, I have seen so many surgeons doing this surgery, and the patient came to me, there is a difficulties in swallowing, and it's a very painful condition. I think, and my comment, can you hear me?
Yes, yes.
Yes.
Okay. Actually, in
Someone
big
shared
lesion,
your screen. Please stop sharing. Someone shared your screen. Okay.
I
Go
don't
on,
know.
Okay.
Unmute yourself. Unmute.
In large excision, I mean the tonsillectomy, during excision of the tonsil, there is a wide area, there is a burning, and this burning will causes there is a fibrosis of the muscles, and the patient may come with difficulty in swallowing. I have seen so many patients comes feeding difficulty, I mean the swallowing difficulty. But if you use this laser very precisely, if you don't injure the muscle, then it will be, I think it will be better. So my last comment regarding the laser, if you do the laser machine, you must have enough knowledge regarding the laser machine and the size of the lesion. So this is my comment to the juniors. Don't go without taking or without acquiring enough knowledge to perform the laser surgery. Thank you very much.
Thank you, Professor Manwar Hussain. Very short, brief comment by Professor Mohammad Yusuf. Please. Yes.
Thank you,
Yes.
sir, for giving the chance to say few words. Sure, sir. I don't have anything to say because when the Kamrul sir is the speaker, nothing to be added. He covered everything about the laser. So one thing is that the doctors are not oriented actually about the laser, and we are not sending patient to senior or where the facilities are available. I do have diode laser and carbon dioxide laser, but not getting enough patient. And one of my comment is when a patient is having suspicion of malignancy, in that case, I think prior MRI should be done before going to surgery. Thank you very much for giving me the chance to say a few words. Thank
Yes,
you, Professor
Professor
Kamrul.
Sheikh Hasanur Rahman. If there is any Professor Nandakisu Sinha, are you there, Professor Nandakisu Sinha? No, Professor Sheikh Hasanur Rahman. Okay, go on.
Sir, I am sharing the screen, sir. Just একটা ছবি দেখাবো, sir.
Yes, yes.
Can you see, sir?
Yes.
এটা হলো আমাদের মাহমুদ স্যার যে পেশেন্টের কথা বলছিলেন। অ্যাকচুয়ালি পেশেন্টটা ছিল 6 বছর বয়সের বাচ্চা, স্যার। স্যার ওই কার্বন ডায়োড লেজার দিয়ে স্যার লেজার ল্যারিঞ্জিয়াল স্টেনোসিস, ট্রাকিয়াল স্টেনোসিস অ্যাকচুয়ালি রিক্যানালাইজেশন এবং স্টেন্টিং করেন স্যার, যেটা 6 মাস পরে টি টিউবটা রিমুভ করা হয়, আবার রিস্টেনোসিস ডেভেলপ করে স্যার। তো সেই ওই ছেলেটাকে স্যার আমরা পরে আবার টি টিউব দেওয়া হয় এবং টি টিউব রিমুভ করার 1 বছর পরে এখন স্যার বাচ্চার বয়স 8 বছর, 8.5 বছর বা 9 বছর এরকম হবে। সো হি ইজ ডুইং ভেরি নাইস নাউডেজ স্যার। তো ওই বাচ্চাটার ছবি দেখানোর জন্য স্যার, আসলে পেডিয়াট্রিক এজে ল্যারিঞ্জিয়াল স্টেনোসিসের রেজাল্ট খুব খারাপ স্যার। তো আমরা সাকসেসফুলি এই বাচ্চাটাকে করতে পারছি আর কি স্যার, জাস্ট দেখানো আর কি স্যার। ওই মাহমুদ স্যার যে ছেলেটার কথা বলছিলেন, এটা সেই ছেলেটা স্যার।
Thank you very much. It's an excellent addition.
আচ্ছা বাবর, এক মিনিট, একটা বাবর, এটা কতদিন আগে আপনি করেছেন এবং এখন কতদিন হয়েছে?
এটা স্যার টিউব রিমুভ করার পরে 1 বছর হয়ে গেছে স্যার।
1 বছর। 1 বছরের ফলো আপের রেজাল্ট কি আপনি দেখেছেন কি আবার?
জি স্যার, আমরা আসলে
এন্ডোস্কোপি করে
এন্ডোস্কোপি করে আমরা স্যার আমাদের এখানে ব্রঙ্কোস্কোপির ফ্যাসিলিটিজ আছে স্যার। আমরা
কিছু পেয়েছেন?
ক্যারিনা পর্যন্ত দেখি স্যার। একটা গ্রেড 1 স্টেনোসিস আছে স্যার, এটা স্টেবল আছে স্যার।
আচ্ছা,
নট প্রোগ্রেসিং স্যার।
আচ্ছা আচ্ছা, থ্যাংক ইউ ভেরি মাচ।
Thank you, sir.
Thank you. We are near to end of our session. Dr. Nurul Naim, are you here with us? Dr. Nurul Naim?
Sir, assalamu alaikum, sir.
Yes, pass your comment in a minute.
Sir, thank you very much, sir, giving me the opportunity to say something in a big gathering and large audience. Thanks to you, first of all. You are arranging a very nice session for all of our ENT surgeons in the globe. And my respected mentor, Professor Kamrul Hasan Tarafder, sir, today he delivered his speech very nicely and very elaborately. And basically the latest for our otolaryngology. And I was also using it from 2009. This was Korean CO2 laser. And all of the panelists, they are saying very good. And I think we should use rational use of this instrument and modern technology and giving the good result for the patient. Thank you very much, sir. সবাইকে আমার সালাম দিচ্ছি স্যার, সবার নাম নিতে পারতেছি না, এই জন্য সময়ের অভাবে আপনারা সবাই দোয়া করবেন। আসসালামু আলাইকুম।
এক সেকেন্ড, একটা ইনফরমেশন একটু দিয়ার জন্য একটু ফ্লোরটা পাইতে পারি?
হ্যাঁ,
সেটা হলো যে এই যে আমরা যে টি টিউবটা ইউজ করি, এটা এখন আমরা আগে যাদের থেকে নিতাম এরা এখন প্রায় 30-40 হাজার টাকা করে এই টি টিউবটা নিচ্ছে। কিন্তু আমরা কোরিয়ান একটা টি টিউব বিক্রি করে আজি সুপার মার্কেটের দোতলায় 26 নাম্বার রুমে, এটা কোরিয়ান টিউব, এটা জাস্ট 7-8 হাজার টাকায়, 8-10 হাজার টাকায় এই টি টিউবটা পাওয়া যায়। আমি বাবর এবং অন্যান্য যারা ল্যারিঞ্জিয়াল স্টেনোসিস নিয়ে কাজ করে, তো ওদের জন্য বলতেছি যে শপ নাম্বার 26 আজি সুপার মার্কেটে এটা আমরা যেটা ইউজ করি, আমরা ওই যে প্রদীপের থেকে যেটা নিতাম ইকুয়াল রেজাল্ট দিচ্ছে, বাট অনেক চিপার রেটে। এবং সুতরাং আমি সবাইকে বলবো যারা ল্যারিঞ্জিয়াল স্টেনোসিস বা ট্রাকিয়াল স্টেনোসিস নিয়ে কাজ করে টি টিউব দরকার হয়, প্লিজ সেন্ড দ্য পেশেন্ট টু আজি সুপার মার্কেট, শপ নাম্বার 26, ফার্স্ট ফ্লোর।
স্যার একটু থ্যাংক ইউ স্যার, মাহমুদ স্যার থ্যাংক ইউ। এই টিউবটা আমি ইউজ করছি স্যার, এটা একটু শক্ত আর ওই যে ইয়ে করার সময় ট্রমাটাইজড হয়ে যায় স্যার।
এখানে আরেকটা প্রবলেম আছে, ভিতরে একটা ভালভ দেওয়া থাকে, ওই ভালভটা খুলে নিতে হয়
স্যার। আরেকটা ইম্পর্টেন্ট ইনফরমেশন দিই স্যার, মোস্ট প্রবাবলি সায়েন্স ল্যাবরেটরি স্যার, আমাদের বাংলাদেশে ঢাকার সায়েন্স ল্যাবরেটরি যেটা, ওরা আমাদের আমেরিকান যে টিউবটা আমরা ইউজ করি হুড কোম্পানির, সেটা ওই সেম কোয়ালিটির একটা টিউব ওরা খুব সম্ভবত 2-1 মাসের মধ্যে বাইর করবে আমাদের সায়েন্স ল্যাবরেটরি।
যাক,
এক্সিলেন্ট ইনফরমেশন, থ্যাংক ইউ ভেরি মাচ। আমাদের সায়েন্টিফিক পার্টনার ইনসেপ্টা ফার্মাসিউটিক্যালস থেকে ডক্টর সঞ্জনা আমাদের সাথে আছেন।
খুরশিদ, আমি একটা মেসেজ দিব খালি খুরশিদ।
হ্যাঁ প্লিজ।
থ্যাঙ্কস অল প্যানেলিস্ট। আর এই মালাখান তো তৈরি করতেছে, এই অলরেডি বাবর যে ইনফরমেশন দিল, আমি তোমার একটা মেসেজের জন্য বলতেছি, খুব সহসাই তুমি একটা বাংলাদেশে যেটা আসা উচিত রোবোটিক সার্জারি। আমি বাবরকে বলবো, বাবর আমরা নো হোয়ার মেনলি বেজোদাটাং আপার লেরিংসে কাজ করার জন্য, সরি মাহমুদ যা বলতেছিল, আমাদের দেশে আসা উচিত, তুমি একটা সেশন করবা নেক্সট রোবোটিক সার্জারি ইন বাংলাদেশ।
Thank you for your advice. Dr. Sanjana from Incepta Pharmaceuticals. Vote of thanks by Dr. Sanjana. Please welcome.
Thank you, sir. Honorable Speaker, moderator of today's webinar, respected panel of experts and distinguished guests. Assalamu alaikum. I'm Dr. Sarjan Rahman, Group Manager, Medical Services. On behalf of Incepta Pharmaceuticals Limited, would like to express the heartiest gratitude to all you and your kind presence. Respected doctors, if you look at our history, probably we will find that Incepta started its journey with something different and innovative approach. From the first day, rather than conventional medicine, Incepta focused on the life-saving and very much needful medicine. Actually, Incepta believes people of Bangladesh should not be deprived from the blessings of the modern medical science. Incepta always value your suggestions. Your presence to this webinar will definitely inspire us to do more. So thank you again for being with us and to make this webinar a very successful one. Thank you and Allah Hafiz. Thank you all.
Thank you very much, Dr. Sanjana, for being present from your company, represent your company, and to continue us with our webinar. Now, I like to request our Dr. Ranjit Kumar Rai, Nath, দাদা আর কে নাথ দাদা, আপনি যদি কোনো কমেন্ট করতে চান, আপনি অনেক রাত পর্যন্ত জেগে থেকে আমাদের সাথে থাকেন, প্লিজ।
অনেক ধন্যবাদ এবং যারা প্যানেলিস্ট এবং যারা অ্যাটেন্ডেন্ট ছিল তাদের সবাইকে ধন্যবাদ জানাচ্ছি। আমার কথা শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে, একটু আস্তে বলেন।
আরেকটু জোরে বলতে হবে?
আচ্ছা, বলছি তোমাদের সবাইকে অনেক ধন্যবাদ। আমার এটা শোনা ছাড়া আর কোনো কিছুই করার নাই। তার কারণ হচ্ছে সত্যি কথা বলতে যে লেজার ফিজিক্যালি আমি এখনো সার্জারি দেখি নাই, তোমার সেই সুযোগ হয় নাই, কারণ তোমরা ইনস্টিটিউশনে প্র্যাকটিস করো, আমি প্রাইভেট প্র্যাকটিস করি, আর তোমরা তো সেটা নাইও। আর ওই শুধু লেজার সার্জারি দেখার জন্য কোথাও যে যাবো সেটাও হয় নাই। আমাকে একবার বোম্বে থেকে একবার ইনভাইটেশন পাঠাইছিল লেজারের উপর ট্রেনিং নেওয়ার জন্য, আমি গিয়ে ট্রেনিং নিলাম, কিন্তু আমি অ্যাপ্লাই করতে পারি। হ্যালো হ্যালো,
রঞ্জিত?
হ্যাঁ হ্যাঁ, ফাইন, থ্যাংক ইউ। নিজাম ফারুক ভাই, আপনাকে আমি অনেকবার টেলিফোন করেছি, আপনি সম্ভবত শুনতে পান নাই। বেলাভাবে মারা যাওয়ার পরে আমি অনেকবার রিং দিয়েছি, আপনি রিং ব্যাকও করেন নাই, রিং রিসিভও করেন নাই। আমি বলছি তার বোম্বে থেকে বোম্বে থেকে ইনভাইটেশন আসলো, আমি গেলাম না, তার কারণ হচ্ছে আমি যেহেতু অ্যাপ্লাই করতে পারবো না, শুধু আমার সময় নষ্ট করে লাভ নেই। যাই হোক, তোমাদেরকে অনেক ধন্যবাদ, কারণ তোমাদের কাছ থেকে এখনো অনেক কিছু শিখার আছে। যদিও শিখতে না পারি, অন্তত শুনতে পারি যে তোমরা কি কি করতেছো, সেটা দেখতে পারি। তার জন্য তোমাদেরকে অনেক ধন্যবাদ। তোমরা অনেক এগিয়ে যাও, বাংলাদেশকে আরো এগিয়ে নিয়ে যাও, এটা আমি কামনা করি। কারণ তোমরা অনেক ভালো ভালো স্টুডেন্ট তৈরি করো, যারা এইসব কাজ করে ইন্টারন্যাশনাল স্ট্যান্ডার্ডে কাজ করতে পারবে, সেরকম ছাত্র তোমরা তৈরি করো, তাদেরকে দিয়ে বাংলাদেশ যাতে এগিয়ে যায়, বিশ্বের মধ্যে আমরা যাতে মাথা উঁচু করে দাঁড়াতে পারি, সেভাবে তোমরা ছেলেদেরকে তৈরি করো। অনেক ধন্যবাদ তোমাদের।
থ্যাংক ইউ দাদা। আমরা অফিসিয়ালি শেষ করে দেওয়ার আগে আমাদের ওয়েবিনার কেউ যদি ইন্টারেস্টেড হন কথা বলতে, আমাদের যারা আছেন আপনারা ভিডিও ওপেন করেন এবং কমেন্ট করেন সংক্ষেপে প্লিজ, যাদেরকে আমরা পাইনি এতক্ষণ কথা বলার জন্য। কেউ যদি আমাদের অডিয়েন্সের মধ্য থেকে, আমাদের কলিগরা বেশিরভাগের যারা আছেন, আমি আমাদের জুনিয়র কলিগ বলবো এই জন্য যে আমাদের সমান পুরা আর কি এখানে খুব কম নাই, কাজে
এখন অ্যাটেন্ডেন্স 30 নেমে আসছে।
এখন নেমে আসছে। যাই হোক, সবাই নেক্সট আমরা ক্লাস পরীক্ষার আবার ইয়েতে চলে যাব। আমরা তাইলে আমাদের অফিসিয়ালি আমরা ফেসবুক থেকে ইয়ে করে দিচ্ছি।
স্যার আমি একটা কথা বলে শেষ করি স্যার, স্যার।
হ্যাঁ নাইম বলো।
স্যার ডক্টর নাইম স্যার, ওই যে যেটা বলতে চাইছিলাম স্যার, যে কামরুল হাসান তরফদার